Why clear aligners? Clear aligners have transformed orthodontics from a niche option into mainstream care. What once seemed impossible, correcting deep bites, rotations, and extractions with removable plastic trays, is now routine in many practices. But aligner therapy is more than just wearing clear plastic. It's a system built on biomechanics, material science, and digital engineering. And like any tool, aligners succeed only when the clinician understands their strengths, limitations, and how to stage movements intelligently. In this masterclass, we will go step by step, from history, impressions, and digitization, to treatment planning, biomechanics, attachments, auxiliaries, and finally, clinical cases. My goal is to give you not only knowledge, but also the clinical judgment to apply it in daily practice. History of clear aligners. The story begins in 1945, when Kessling introduced a rubber tooth positioner to make small corrections after orthodontic treatment. By the 1990s, orthodontists were using vacuum-formed retainers like Essex for minor tooth movement. The real revolution came in 1997. Align technology launched Invisalign, combining digital scanning with CAD/CAM fabrication. For the first time, orthodontists could plan entire treatments virtually and deliver tooth movement in small, sequential steps. Today, aligners are used globally, supported by advanced polymers, machine learning and staging, and adjuncts like attachments and elastics. Analogy. Think of aligners' history as 3 chapters: positioners, typewriters; Essex retainers, desktop computers; Invisalign, smartphones; impression techniques and digitization. Aligner success depends on accurate impressions or scans. Any error here multiplies throughout treatment. 3 main techniques. 1. One-step medium body PVS, fast, but often misses distal molars. 2. Two-step putty plus wash, more accurate, captures margins better. 3. Custom tray with light body wash, highest precision, lowest error risk. Common errors include voids, drag defects, and incomplete molar capture. Clinical pearl: never send an impression missing distal molars. That aligner will float like a loose crown, losing retention and accuracy. Virtual setup and digital manufacturing. With accurate scans, aligners are digitally staged. Teeth are virtually segmented, and planned movement is divided into small increments, typically 0.25, 0.3 millimeters, 0.3 millimeters per aligner. Originally, aligners were made by destructive scanning of plaster models. Today, 3D surface scanning and stereolithographic printing dominate. This allows greater precision, reproducibility, digital storage, and manipulation. Analogy. Think of virtual setup as a GPS route. Each aligner is like a turn in the journey. The full set is the complete map from start to finish. ClinCheck and digital treatment planning. ClinCheck is the brain of Invisalign. It lets orthodontists visualize treatment from start to finish. But remember, software is only as smart as the person behind it. Key clinician tasks. Define treatment goals. Control staging of difficult movements. Anticipate biological limits. Clinical case. A patient planned for 3 mm lower incisor intrusion in ClinCheck. In reality, aligners delivered only 1 mm. Without attachments and overcorrection, the plan was doomed. Lesson. ClinCheck is a tool, not a guarantee. Interproximal reduction, IPR. IPR is fundamental to aligner therapy. By reducing enamel between teeth, space is created for alignment without extractions. Techniques include strips, hand files, diamond-coated, discs, air rotor burrs, clinical pearls. Always polish and fluoride treat after IPR. Never exceed 0.25 mm per contact per visit. Plan space distribution intelligently across the arch. Analogy. IPR is like sanding wood before fitting a puzzle. Small adjustments make the entire structure fit better. Staging of tooth movements. Staging determines how teeth move, all at once or in sequences. 2 main strategies. Simultaneous staging, multiple teeth move together. Efficient but higher error risk. Segmented staging, controlled, stepwise movements. Slower but more predictable. Example. Rotations of canines often staged later after anterior alignment to maximize aligner grip. Biomechanics of clear aligners. Aligners move teeth differently from braces. Instead of wire force through brackets, aligners apply surface pressure over crowns. Force characteristics strongest on insertion. Decline rapidly in 24-48 hours. By day 6, aligners are mostly passive. Predictable movements, tipping, alignment, minor rotations, unreliable movements, extrusions. Torque. Large rotations. Clinical Pearl. Always use attachments for torque and extrusions. Analogy. Think of aligners as spring-loaded gloves. They grip and squeeze, but only within their elastic limits. Attachments and power ridges. Attachments act as handles for aligners. Shapes include rectangular, retention and torque, beveled, rotations, ellipsoid, vertical control. Power ridges are small indentations in aligners that deliver torque. Clinical Pearl. Attachment placement matters more than design. A poorly placed attachment is as useless as a handle glued in the wrong spot. Auxiliaries, elastics, and mini-screws. Some movements exceed aligner capability. Enter auxiliaries, elastics, correct Class 2 or Class 3. Mini-screws. Provide anchorage for intrusion or distalization. Case example. A deep bite corrected with anterior intrusion was only successful after tabs were added. Aligners alone could not achieve it. Managing difficult movements. Unreliable movements include extrusions need attachments, plus elastics. Rotations require beveled attachments. Plays over correction. Torque requires power ridges. Plays staged movement. Case Pearl. Always expect only 50-60% expression of programmed movement. Plan overcorrection accordingly. Invisalign Teen. Invisalign Teen includes compliance indicators, eruption tabs, and replacement aligners. It accounts for mixed dentition and growth changes. The compliance indicator, a blue dot that fades with wear, gives feedback to both orthodontist and parents. Periodontal considerations. Aligners cover gingiva, which raises concerns. Do they harm periodontal health? Studies show aligners cause less plaque accumulation than braces. Patients report improved comfort and hygiene. However, aligners can cause gingival stripping if overextended. Clinical Pearl. Trim aligners scalloped or straight, depending on retention versus comfort needs. Clinical cases and failures. Not all cases succeed. Failures include poor tracking, aligners not seating fully, white spot lesions from poor hygiene. Case example. A 24-year-old with posterior open bite after aligner treatment, caused by posterior intrusion due to occlusal coverage, managed with finishing elastics and refinements. Conclusion. Clear aligners are not magic. They are tools, powerful, but only when guided by skilled clinicians. Mastery comes from knowing biomechanics, staging intelligently, and intervening when aligners alone are insufficient. Every successful aligner case reflects the partnership between digital technology and clinical judgment. And that is the art of modern orthodontics.